So today I'm going to be showing some recently published work that we've done when modeling work on the age of last screening and the remaining lifetime risk of cervical cancer. So I have no personal conflicts of interest to declare. The funding for the research that I will show you today comes from the Cancer Research Society and the Canadian Institutes of Health Research. So why did we decide to look at this question? So a lot of it was due to demographic trends, in fact. So cervical cancer mortality rates do increase with age. And so there are some good arguments for why we might potentially want to screen or keep on screening as women get older. And most countries are facing aging populations, which will lead to more cancers that are to be diagnosed in women who are 65 years and older. And there is good evidence that cytology screening in women who are 65 years and older can prevent cancers at older ages. However, when it comes to HPV, screening with HPV testing, which is a test which has a much higher sensitivity than cytology, I think that there is an argument to be made that continued screening at older ages may not be warranted given lower benefits versus the same harms. So why would we want to use a decision model to look at this question? The simple answer is that for this question, we need to extrapolate results from many clinical trials and observational data to perhaps different ages, using different screening intervals and using different algorithms than have been used in the past. And decision models like ours have been used to assess benefits, harms, and cost effectiveness of screening recommendations in the US, the UK, and in Australia. So I think that there is increasing demand for using decision models to help raise decisions on what type of cervical cancer screening algorithms we want to have. And I would like to point out that the main reason that I think that decision models are useful is because there is a significant time lag between the moment that you screen a woman and the moment that the cancer actually gets prevented, which is likely for most women to be between 5 to 20 years. And this is very easy to see based on just natural history data, where the peak of HPV infection is at a very early age. You would expect the peak of high-grade precancer prevalence to be, in early adulthood, and peak cervical cancer incidence occurs in mid to late adulthood. So to look at this question, we used a state transition Markov model of cervical cancer natural history and screening. We have calibrated the model to Canadian cervical cancer epidemiology, so it reproduces cervical cancer incidence by age, SIN prevalence, and HPV prevalence by age. The model, it simulates cohorts of women from ages 10 to 100. And importantly, I want to emphasize that the results I'm going to show today are for unvaccinated cohorts. We're still working on implementing vaccination into the model. However, I do believe that there's a lot of insights that apply to unvaccinated cohorts that likely also apply to vaccinated cohorts. On the right-hand side here, you see the algorithms that we implemented into the model. They are much simpler than many of the algorithms that I've seen for different countries that are quite complex and span very many pages. The objective was mostly to reproduce the broad strokes of how cytology-based screening and HPV-based screening is done in Canada and also in multiple other countries. In terms of outcomes, in order to measure screening health benefits and harms, we used a variety of different outcomes. So one of the main ones was trying to measure the absolute cancer risk and or cervical cancer incidence rates. Absolute risks are useful in the paradigm of risk-based management and when you're using target thresholds. So for example, the World Health Organization target threshold of less than 4 cancers per 100,000 women would constitute an absolute cancer risk threshold. We also looked at metrics of balance of benefits and harms, and the ones I'm going to mostly show today are net benefit measures in terms of quality adjusted life years. So the idea is that we are measuring the quality adjusted life years that are gained from preventing cancers and deaths due to screening, but we are also applying a penalty due to quality of life that is lost due to screening tests and procedures. So the inconvenience that comes from attending screening, the potential anxiety that comes from being screened positive, and any pain or discomfort that comes from treatment procedures. I do want to point out that there are issues in terms of age equitability when we look at different outcomes. So if we look at screening benefit in terms of cancers prevented or in terms of cancer risk, then it means that we are treating all cancers the same, regardless at what age they occur. However, if we are measuring screening benefit in terms of life years and quality adjusted life years, it does mean that we are placing more value on preventing cancers at younger ages, because if we prevent a cancer at age 35, that woman will likely live longer than a woman who would have gotten cancer at age 70 and who died. So these are some of the results from the model, which were the earlier published results. So I'm going to focus on the left-hand side of the slide here. Which are the 5 years predicted risks of developing cervical cancer for women who stopped screening at different ages. And on the top here, you have a woman whose exit test is cytology normal, and at the bottom you have the risk for women whose exit test is HPV negative. So comparing a cytology screening paradigm with an HPV screening paradigm. And I also added this line here for 4 cancers per 100,000 women per year to give a reference point, essentially, of what this looks like in terms of cancer risk and in terms of thresholds that we already have. So if we look at a woman who, say, is 55 years of age and who has a cytology normal test and decides to stop screening after that. Well, in the short term, her risk may be quite low, but due to the low sensitivity of cytology screening, we do expect that her risk would likely go up as she ages again. And so an exit cytology normal test is likely not a very good basis on which to stop screening, at least at age 55. But as women get older, obviously the risks go down. However, with HPV testing, even a woman who's 55 years old, if she is HPV negative, there is a very low risk that she will reacquire HPV as she gets older. And so the long-term negative predictive value of an exit HPV negative test is quite high at older ages. And even to the point where we might be able to achieve that threshold in those age groups of less than 4 per 100,000 women per year. And on the right-hand side here, you see what it looks like in terms of cancer incidence at different ages if the general population stops screening at different ages. These are the newer results from a model that just came out this year. This figure is quite complicated, so I'll try to go a little bit slower. I think that the best way to look at it is to look at what happens if you screen a 35-year-old woman. So this graph shows what are the quality adjusted life years benefits, the cumulative adjusted life year benefits of screening once at each age for 100,000 women. So you can see, if we look at the orange line here, which is what happens if you screen a woman who is 35 years old, you see that there is an immediate loss of quality of life due to the immediate screening harms. So many women are HPV positive and they are anxious because of that. Many of them have to be treated. However, in the long term, we see that the cumulative net quality gains go up due to the prevention of cervical cancers and the prevention of cervical cancer deaths. And so, in the end, it's as would likely be expected. We do think that the benefits largely outweigh the harms of screening a 35-year-old woman. However, there is, a 15 to 20-year lag between the time that the harms occur and the time the benefits occur. Screening a 35-year-old woman is expected to prevent 843 cancers per 100,000 screenings, leading to 24 average years of life gained per prevented cancer death. However, as we get older, after the age of 35, the efficiency of screening tends to go down. So if we look at, say, screening a woman who is 65 years old, this woman would still have the harms of screening, but the benefits of screening in terms of potential life years gains are much less. And so we think the model predicts at least that a woman who is 65 years old and who's never screened before and who gets screened, she would only have 7 average life years gains per prevented cancer death. And unfortunately, after that, the benefits decrease even further. So the model predicted that screening a woman who is 70 years old, who has never screened before, would likely only gain 1 quality adjusted life year per prevented cancer. And the reason for that is that unfortunately the expected life years that can be gained go down as we get older. I just wanted to point out that this is not necessarily new information in the sense that other models have predicted this before. So if we looked at these results from Kim and colleagues that were published in 2018. I'm showing here a figure that was in the appendix, so you'd have to dig a lot to find this figure. But essentially, they predicted somewhat the same thing, where if you look at cytology screening, which are the triangles here on the figure, then the age at which you stop screening does seem to matter a little bit. You can gain a few additional life years per 1,000 women screened with cytology. However, if you screen with HPV testing, then the end age has actually quite little impact on how many life years are able to be gained. The big gain comes from switching to from cytology to HPV testing, and not necessarily from increasing the age at which you stop screening. So in summary, I just wanted to point out the predictions are generally not very different between models, even if they're calibrated to different countries and make different assumptions. Most of them do predict that benefits of screening are low below 25 years of age and decline after the age of 65. And screening efficiency is highest between 30 and 60 years old. Much of what I'm trying to convince people is the decisions regarding ages to screen depend a lot on the value judgments and the interpretations that are made by decision makers. And so these are questions of value judgment. Although, what threshold do we think that cervical cancer risk is sufficiently low not to screen? How should we value harm outcomes versus benefit outcomes? Few of the women who screen will benefit from their screening, and many more of them will incur harms, but the women who do benefit will benefit a lot because they may potentially gain very many life years from their screening. There's also the question of, should we value all cancers equally, or should we favor reduction of early mortality? And also, I did not touch a lot on cost effectiveness because that's not what I researched, but there's also the question of what is the cost effectiveness threshold? How much do you want to pay to reduce, to prevent cancer? I do want to acknowledge many of the co-authors who worked with me on this research, members of the Division of Cancer Epidemiology at McGill University, who also contribute a lot to my thinking, and of course, the funders who funded this research.